This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
Ten tips, 20 minutes. Here we go. Let's rock and roll. Okay, we'll start with supplements for tip number 1. How do they squeeze all the great nutritious things that come in those foods into those tiny little pills that you're supposed to take? Okay, I'm not quite sure. Recently in the Journal of Cardiology here, they had a list of supplements that people take for cardiovascular issues. And here's a list of the ones that are probably more familiar, but then there's a whole list of other ones that are maybe not so familiar. And if we go through all of these, some of them are for lowering cholesterol or triglycerides. Some of them are supposed to be antioxidants. American Heart Association just had a recent advisory statement suggesting that vitamin E, vitamin C, beta-carotene, and many others really don't prevent heart disease. Now, the interesting thing is these studies started out looking at epidemiological data. They looked at populations that had more vitamin E or C or beta-carotene in their blood, and they had less heart disease. And how did they get more vitamin E or C or beta-carotene in their blood to begin with? They ate more fruits and vegetables and things like that, right? So you can't always just take the putative active agent out of the food and assume it's going to work the same way. So these trials have been really disappointing in terms of supplements. Okay, the one that's worked so far better than others has been fish oil. It's these omega-3 fatty acids that I'll bring up again when I talk about fish. This is the most compelling trial to date, and I just want to show you how compelling it is. So we have 11,000 plus women and men who are myocardial infarction survivors being followed for 3 to 5 years on fish oil or a placebo. And you can see that after 3 to 5 years, there's a 10% reduction. It doesn't eliminate heart disease, but there's a 10% reduction. And the bottom line here is if you translate this into number needed to treat, 80 people had to take the fish oil supplements for 3 to 5 years for one person to know the difference. So that's how many lives they saved. So you can't go out and have your Big Mac and your Whopper and then come home and pop an omega-3 pill and be okay. That's just part. So it adds to all the other things in your armament. Okay. And please know that because of the Dietary Supplement Health Education Act of 1994, there's absolutely no regulation of the supplements that you buy on the shelves. Okay? So Congress passed an act that if these things are derived from foods, the FDA doesn't have jurisdiction to regulate them. So they don't have to prove they work. They don't have to prove they're safe. The onus is entirely up to the manufacturers of the supplements themselves. Now, if you want to know what's in your supplement, because some of them don't actually even have what they say is in them, you can at least join consumerlab.com here, which is on the web. It used to be free. Now it's $27 a year for a subscription. And they haven't analyzed all the supplements out there, but they've analyzed quite a few of them to determine if they really have the levels in them of what they say they have. And they don't all do that. So at least this is in your favor. Won't tell you if it works or not, but just if it has in it what it says it has. Okay, tip number 2, let's go to fish. I really think these omega-3 fatty acids in fish are fascinating. They seem to be good for lowering triglycerides, for blood pressure, for being antithrombogenic. Fascinating set of effects if you eat the fish. And what about if you take the fish oil supplements? Well, the extra benefit you get if you eat the fish is you probably replace something else you're going to eat. And that'll be a common theme in what I say today. Okay, so maybe part of the benefit is you were going to have a Big Mac and instead you had fish. So maybe there's a small benefit to the fish and an added benefit to what you replace. So I'm actually a vegetarian, just so you know. I haven't had any fish in 20 years, or meat or chicken. But I'm really convinced that the omega-3 fatty acid data and the fish data are fascinating, and it's a really nutritious source of food. So I'm a fish fan. These are the ones that have the most omega-3 fatty acids. And then you may want to ask me which ones have the most mercury. Well, I don't have that list with me today, but there are plenty of lists, and there's ways to go about this, and look for sources, the Berkeley Wellness Letter, Nutrition Action Letter. You can go online and see which types of fish are more likely or less likely to have mercury, and which ones are more or less likely to have the omega-3 fatty acids. So I encourage you to be an activist and look for those. Salads. Oh, this is the heart of my diet right here. How many of you in the last week ate something that came from a pre-packaged, washed salad mix? Audience participation time. This is one of the big boons to nutrition that I have seen in a long time. It's fabulous. You can get them anywhere. You can get them in bulk, or you can get them in bags. I really think this is a fabulous way to make life a little easier for me. And I'll just give you my hint. Every week, I have a salad spinner. I still wash it, even though it says it's washed. I still wash it, okay? And then I cut up a whole bunch of veggies that are pretty hearty and last for the week. So I cut up broccoli, carrots, bell peppers, and I couldn't find purple cabbage in the clip art on the web, so this is the green cabbage. But if you put purple cabbage, it's extra colorful. And these actually last for almost a week if you prep these ahead of time. So I'm sure I have salad once a day. And when I go to work, I just whip into the fridge and grab my salad and put it in a little takeout thing for work. Okay, so there's my salad tip. That would be a quickie. Soups are everywhere, okay? You can make them yourself. How many of you made soup in the last month? More audience participation. Wow, oh, that's really good. That might even be more than the salad. I'm really impressed. Okay, soup's relatively easy to make, and it's fabulous because you can make a huge pot and then save some for the next day and freeze some for the next week. You can go buy canned soups, lots of canned soups, and I was really interested to see that Health Valley now has a whole line of organic soups with no salt added. Okay, 45 milligrams of salt in this canned vegetable organic soup right here. So I'll put in a plug for soups, given that a lot of us are pressed for time and we need quick things. What could be quicker than soup? Okay, and I'm so proud of you that you're all making these at home. That's magnificent. Okay, next tip is nuts. Nuts really got a bad rap for a while because we were on the big low-fat scare. And nuts really are almost all fat. Okay, but get over it because they really have a lot of other great things in them. Okay, the fat that they have is mostly unsaturated fat. There's very little saturated fat, which is the bad one, at the very bottom of this list. Okay, lots of mono and polyunsaturated fat. Interestingly, almonds have more fiber than the rest, and most of the nuts in particular are monounsaturated fat rich, except for walnuts. Walnuts tend to be more polyunsaturated. I don't know if you want to really get caught up in mono versus poly. I really don't think it's all that critical. Unsaturated fat over saturated fat is a much better choice. Okay, so lots of nuts. They really don't differ that much on protein or carb content. Type of unsaturated fat, yes, but very little saturated fat. So go for the nuts and seeds. This is an ounce of almonds, cashews, walnuts, or pistachios. Okay, not a huge handful because they are full of fat, but that's an ounce. Okay, 160 to 175 calories right there. Okay, next tip would be soy. How many of you had some form of soy in the last week? More audience participation. Woo! Okay, we're getting more numbers every time here. Okay, how many of you saw in the newspaper the article in the last couple days? Because American Heart just came out with a new scientific advisory that I am so fully behind. And I hope everybody appreciates the way that the advisory statement was written. Soy is not magic. It's just really good food. It doesn't stop menopausal symptoms. It doesn't cure cancer. It doesn't stop heart attacks. It really doesn't lower your cholesterol unless you eat 50 grams a day every day of the week, and then it only lowers it 3%. A lot of the health benefits of soy have really been overblown. However, I love the last line in the advisory statement, which says, okay, it's not magic for all those things that have been touted for the last decade, but it's got fiber and minerals and unsaturated fat. It's got really high quality protein. It's a really nutritious food. But it's really not a magical food. So it's another thing. You can't have your burger and your Whopper and at the end of the day have a soy pill or an isoflavone pill. So this is so new, I actually don't have the dates of the pages on the right there, so I tried to cite the science advisory statement, but it just came out this last week. Now I want to point out really quickly how fun soy is. Okay, it's got more protein than any other plant food out there, if you're interested in protein. The fat, again, is mostly poly and monounsaturated. Soy is one of the few sources that has the omega-3 fats in plant foods. Mostly you have to get those from marine. Now I will have to say the The omega-3 fatty acids in the plants aren't exactly the same as the ones in the fish, so they might not be as beneficial. But it's one of the few plant sources of omega-3 fatty acids. And John Cook and others on campus have done some fascinating work with arginine as having some cardioprotective effects. And plant foods, plant proteins in general have more arginine, which is one of the amino acids, relative to other amino acids than other plant foods, and especially relative to animal foods. More arginine per gram of protein in plant proteins and soy in general. Okay? Now what are you going to eat? Are you going to eat the whole bean? That would be a good choice. Any edamame fans in the audience? I'm a huge edamame fan. Okay. Okay, and then tempeh, you take the whole bean and you ferment it. And then for those of you who have family members who really were sad giving up their meat, it chops up into squares and it's chewy and dare I say meaty, or there's a lot of texture to it. Now soy milk is out there in all the stores right now, but know that soy milk has been processed. It's lost all the fiber, and it doesn't have very much folic acid anymore. And then if you make tofu out of it, they actually process the milk to make the tofu, so you've lost some more. So every step along the way you lose some, right? So the bean is probably the best. And then we've got all kinds of products, including veggie burgers, which are probably a good substitution for beef burgers. However, when it comes to soy hot dogs and soy ice cream, I don't know. If you're going to have ice cream, I would rather eat the ice cream, because I don't really think there's much soy by the time you get to the ice cream and the soy snacks at that level. Okay? Soy is really good, but look how much processing has gone into it. Okay, vegetables and fruits. I'd like some more audience participation here in just a minute. How many of you recognize this as it rolls off your tongue as fruits and vegetables? Well, I want to convince you that a lot of fruits are a lot of sugar, especially fruit juices where they've taken out the pulp and things like that. If you're trying to get your 5 a day, it's certainly easier to pop an orange or an apple into your pocket, but really a lot of the vegetables are more nutrient dense than the fruits. So if you join me here, can you just try letting it roll off your tongue? Vegetables and fruits. 1, 2, 3. Vegetables and fruits. I love that. Thank you. Okay, so produce for better health pushes the 5 a day message, but interestingly they have a new twist. Instead of saying veggies or fruits, they say 5 colors a day, which I think is a fabulous new twist. So if you go out there and use your vegetables first and your fruits second, and you get 5 colors a day, you probably got some good nutrition. If you had white French fries and white potatoes and white mushrooms and a white banana, then you probably didn't do as well as you could have for your vegetables and fruits. Fair enough? Okay. Whole grain, now this is not as opposed to half grain. Whole grain is the whole kernel. So I'm probably preaching to the choir here, but we know that when we process all those breads and pastas and bagels and things, we've taken out the fiber and we've taken out a lot of the nutrients, we've taken out a lot of the fat, so that the bugs won't like them when they're sitting on the grocery shelf. And the bugs don't eat the bread on the shelf because they're not stupid, they're not very nutritious anymore when you've taken all that out. So it's great that the latest American dietary guidelines have shifted and been more specific. They used to say try to get more whole grains. Now they say try to get at least half of your grains from whole grains, which I think is a great plug. So they're out there. You can get whole grain pasta now. You can get whole grain bagels and pizza crusts. So you'll get more fiber, you'll get more nutrients if you eat those types of carbohydrate-rich foods. Okay, now we're just finishing a study comparing some diets. Okay, so you want to lose weight, right? So we'll go to Diet Wars is one of my tips. You can go low fat, you can go low carb, you can go high protein, or something in the middle. What I really like is Bob Eckel's latest statement for American Heart. There's so much confusion here. What we really ought to be eating is a low-fat diet, okay? If you look at this, we're really much smarter than low-fat, low-carb, low-protein. Okay, everybody pretty much agrees that we should be minimizing refined carbohydrate snack foods that are mostly just carbohydrate without the fiber and the nutrients that go with it. Okay, but if you're going to eat a high carbohydrate diet, or the carbohydrates that you choose should be, depends which way you want to call it, high in fiber, or low glycemic index, or complex, or bulky, or high water. Very hard to get people to agree on exactly what to call this, but we all kind of know in general what those foods are. Okay? And for fats, the monos and the polys, and particularly the omega-3 fats. And for protein, if we choose marine protein, we get omega-3. If we choose plant protein, we get fiber with it. And if we choose animal protein, let's go with lean animal protein and avoid the saturated fat and cholesterol. Okay? So the good carbs, the good fats, the good protein are in these types of foods. Right? So I'm not sure if the real question is high carb, high protein, high fat. I think it's the types that we choose. Okay, I'm going to finish up with a tip on organic, canned, and frozen. Okay, so I get these questions all the time when I give lectures, and you know, we are never going to answer these types of questions in clinical trials. Imagine me randomizing half of the room to eat organic and half commercial for the rest of your life to see who dies first. It's not going to happen. So intuitively, maybe organic sounds better. Intuitively fresh sounds better. Genetically modified doesn't sound so great. Seasonal always sounds good. How many of you have a garden in your backyard and every day you pick all your food seasonal and fresh out of the garden? We can't really do that, right? Okay, so think about this. Somebody picked some fruit or some vegetables in Chile, and they put them on a truck and a ship and a plane, and they came here and they sat in the back room, and then they got put out front, and then you picked them fresh produce out of your market. Or you went for the frozen, because it got frozen on site, and it probably kept more of its nutrients than after all that travel. So when people ask me, oh, you know, there wasn't any organic, so I decided not to buy it. Okay, so great. There was commercial broccoli there and no organic broccoli, so you had a Big Mac. That was really a poor choice, okay? I remember a girlfriend a long time ago really teased me because I went for the organic green bell pepper that was mealy and full of things, and the commercial one was crisp and bright and robust right next to it. And she said, okay, don't take this thing too far. There's worms in that one, and it's full of wrinkles. Come on, get the commercial one this time. So it's always choices. If you don't get the organic, just make the next best choice. Okay, to recap. Supplements. There's not really very many that work, maybe fish oil, but there's really no regulation. The fish look great. Watch out for the mercury. Max out on the omega-3s. Salads are so much easier for us. Soups are everywhere. Soy's not all it's cracked up to be, but it's a good food. Nuts, high in fat, but there are good nutrients in those. Veggies and fruits, see if you can help me work on that. Veggies and fruits, not the other way around. The whole grains, the diet wars, and the organic versus canned versus frozen, whatever. And when it's all said and done, I call it a plant-based, appropriately processed diet, a variety in moderation, and we're so lucky to be able to take advantage of lots of cultures around the world that have had plant-based diets for thousands of years, where they had chicken and beef and fish, and they often flavored their foods. They didn't have a 12-ounce steak. They had a stir-fry, and they flavored it with strips of beef and things like that, right? We can take advantage of the hummus and the tabbouleh and all the great spicy foods. Okay, that said, there's the 10 tips for the day. Thanks for your attention.
So it's a pleasure to be here this evening, and it was a great introductory talk. It's a hard act to follow. I guess I'm going to take things from the other direction. Instead of talking about things that go from the outside in, I'm going to talk a bit about how we look at what's actually going on inside your body. And I wear two hats. One, I'm, as a cardiologist, interested in the imaging side, but also interested very much in the preventive side. So why is a male cardiologist up here speaking about women's heart disease? Well, it's the #1 cause of death in women as well as men. Many of my patients are obviously women. And heart disease, as I'll show you, there's growing evidence that heart disease is different in women. And imaging actually may play an important role in being able to understand that difference and see the disease in women. And I do have some important women in my life who happen to be here today to join in. So I have a lot of reasons to be up here this evening. So cardiovascular disease is a big problem in women. And Latha will speak more to this, but I really just wanted to put up some of the numbers. And while the bars are not labeled here, the red bars here happen to be the men. The women happen to be the white bars. And if you notice, the bar for A, which is cardiovascular disease as a cause of death, the bar is taller in women than it is in men. So as women are living longer, actually the number of women who die every year of heart disease now outnumbers the number of men who die from heart disease. So what is coronary artery disease? Well, this is just one example. the coronary arteries are the tubes or blood vessels that supply your heart muscle. And turns out they're not very big. So the size of that opening is about 1/10 of an inch. And that's what keeps us all alive. And unfortunately, as we eat some of the not so healthy foods we heard mention of, that some of the plaque and fat and things can build up inside the arteries. And you see kind of that glistening, shining substance there that instead of just a simple circle with a thin wall all the way around, that plaque builds up in the artery and starts to gradually narrow that very small tube that's supplying our heart muscle. So what happens over time? Well, it turns out that even in teenagers and people in their 20s, plaques start to form. And the disease develops clearly over decades, since most people don't have heart disease that they're aware of until later in life. Unfortunately, we don't have a great way to predict exactly when heart disease will strike any particular individual. What the progression is, and this is taking one of those tubes of the coronary arteries and cutting it along the long way. So along the left, you see a nice normal-looking tube. And as plaque builds up, it gets, the tube gets narrower and narrower. And the classic heart attack is, as shown by what looks like a little flame protruding there, is that the plaque will rupture, or as I heard on the radio last night, explode was the term that was used. And so if you go back to a cross-sectional view of the artery, you see the blue or purple there is the blood vessel wall, and the red is a blood clot that's formed because the blood vessel wall developed a crack or a rupture in it, and that caused your body to try and seal off that, just like if you cut your finger, and by forming that blood clot to seal where it cracked, the blood clot happened to also block off your heart artery, and the heart not getting blood or oxygen caused damage, can cause a bad heart rhythm, and can lead to death or to myocardial infarction or heart attack. Well, it turns out that this is only one form that can cause a heart attack. And in women, they're very susceptible to a different form called plaque erosion. I won't go into the details, but instead of a rupture or explosion of the plaque, that the surface can erode, and a blood clot just forms on that surface and can lead to similar problem of impaired blood flow to the heart. But this is just one set of data that shows that heart disease in men and women is not exactly the same. So I don't know how many of you, when you picked up your newspaper, it was just yesterday, this was on the front page of the New York Times. Women are said to face hidden heart disease risk. So both the two major journals of cardiology, the American Heart Association journal called Circulation, and the Journal of the American College of Cardiology, both have articles this week on heart disease in women. And this, I've taken a few slides from those articles. And I wanted to point out a couple of things here. So one of these articles focused on a National Institutes of Health study looking at women with heart disease and symptoms of chest pain. And what they found, if you look where I circled, it's hard to read the small type, but what they did was in patients who had typical heart pain symptoms, they sent them for an angiogram, which we consider our best test to see those blockages and narrowings. And by going by classic criteria of risk factors and age, they predicted that about 2/3 of the women would have blockages in their heart arteries. And in that set of patients, who were the women 45 to 55 years of age, it turned out only 20% did. If you then look at the other spectrum, so the women that cardiologists say, well, this is not, they have a chest pain, but this doesn't sound like typical heart pain. When they were sent for an angiogram, the typical predictors would have said only about 7% of those women would have had blockages, and it turned out that 21% did. So our typical way of listening to a history and listening to symptoms does not appear to be as predictive in women as it is in men, probably because a lot of the data has been focused on men. But again, this is more information that helps us to try and broaden our view of women's heart disease, that it's not just men's heart disease that's happening 10 years later. And as part of that, typically when men are sent for an angiogram and have typical symptoms, about 80% of the time, 70 to 80% of the time, they will have narrowing seen on angiography. In this particular study of almost 1,000 women, that almost 2/3 of the women did not have significant blockages. And then one more slide from this National Institutes of Health cohort of women that's been followed at a number of institutions where they looked that even in women who did not have significant blockages, there was still an increased risk of death of myocardial infarction beyond what you'd expect. So, and this is some of what was in the article in the New York Times as well as in the discussion on NPR, that women can have chest pain symptoms and won't have the typical blockages, but still appear to be at risk for heart attacks. So how do we diagnose heart disease in women? Well, as you'll hear from Latha, going over risk factors is still a very important issue, and that still helps us in trying to assess women for their risk for heart disease. A careful assessment of symptoms, and part of what I showed earlier is that women with typical symptoms seem less likely than men to have blockages, and women with what we would consider atypical symptoms seem to be more likely than men with atypical symptoms. So other symptoms of shortness of breath or fatigue beyond the classic chest pain appear to be important. And in particular, what is most indicative of heart disease are symptoms that come on when you exert yourself and typically improve or resolve with rest. And those are things to be particularly aware of if there's a limitation or symptoms that develop related to exercise or exertion, particularly going up an incline or going upstairs. Stress testing in women who have symptoms, either typical or atypical, that we're trying to diagnose evidence of heart disease. There are a number of studies that show that the standard stress test, where they get an EKG, is not as helpful in women. And we typically rely on imaging the heart before and after stress to better diagnose blockages or heart disease in women, and I'll show that data. And then we do, in terms of trying to assess risk in women, even without symptoms, there are times we want to look for evidence of silent disease. So being able to image plaque buildup in the arteries even before we get to symptoms, because we can still intervene by improving lifestyle, improving exercise, improving diet, and potentially incorporating medications to lower cholesterol, blood pressure, blood sugar, etc. So coronary calcium scanning is used for this as one example. And then I'll touch on a number of more advanced imaging tests that have been developed or in development, including MRI, to try and detect some of these abnormalities. I mentioned stress testing in women. Again, a somewhat busy slide, but if you look at the very bottom line, which is the average of several other studies that were done, what I've circled is the stress testing with the echocardiogram done at the same time. And on average, that's right about 80% of the time for a non-invasive test, which is not too bad. Not, you'd like 95%, but if you look at just the EKG, which is to the left, that's only right between kind of 60 to 70% of the time. And on the right is a nuclear imaging technique, and that is more in between the 70 and 80% accurate. So the stress echocardiogram for women has been the best non-invasive test to date for detecting blockages in the heart arteries. I mentioned coronary calcium, and I just wanted to show an example of what that is. Normally, the heart looks gray on a CAT scan where you see blood, but as plaque builds up, you get calcium in the arteries, and that appears as very bright on a CAT scan, which is like a fancy X-ray. So that shows extensive calcium buildup in the coronary arteries. And in several studies, the presence of calcium has been more predictive than other individual risk factors for having heart attacks. So in some patients where we're trying to decide, is this patient a low-risk patient or a high-risk patient, do we need to be more aggressive about lowering cholesterol, starting a medication? The coronary calcium scan can help us because we have measures of what's normal for women of different ages that see if you have less calcium than normal or more, and that can help us in the treatment and risk assessment. I did want to show two studies that were mentioned as part of the recent article in the New York Times and this large study of women with chest pain and heart disease. So one used MRI, and this was actually several years ago, and directly measured changes in the heart muscle that occur when the heart doesn't get enough blood or oxygen. And it turned out that even in these women whose angiograms the doctors said it looks normal, that in a subset of women they found that the metabolism of the heart changed with stress, so they actually did get ischemia, that lack of oxygen or blood to their heart, that explained their chest pain even without evidence of the typical blockage that we typically look for. In another study, I don't know how well this shows up, but what the arrows are pointing to is a dark ring around the bright center. So that's a contrast agent that's given by MRI, that the heart pumping chamber, the very bright circle in the middle, is the pumping chamber itself, and then the muscle that surrounds it. When you look on the left, before any kind of stress, the area around the pumping chamber just looks a uniform gray. But when you look on the right, the area right around the chamber is darker, meaning not as much blood is getting to that part of the heart muscle. And this was in women with, one of the terms, syndrome X, has been used to describe a phenomenon where women have typical chest pain but do not have blockages on the heart arteries from the angiogram. And this was also one of the first studies to show that that we can image abnormalities that show blood flow is impaired, even though our standard test didn't detect that. So what are some of the future developments in cardiovascular imaging? So many of you have probably heard of the 64 detector, 64 slice CT scan. So this is a more sophisticated than looking at the calcium. It involves giving contrast and getting finer detailed images. And Jeff Rubin here at Stanford is an expert in this. And what it starts to let you see is not just the calcium, but also the parts of the plaque that don't have calcium in them. So it gives a more extensive picture, and that's just zoomed up. And then another example here, the bright part is the blood flowing through where the contrast has gone. And then the gray next to it shows some soft plaque that can also be, the image can be looked at in cross-section. And so this is really just at the beginning of trying to look at these different plaques and try to understand how much that can help us in predicting risk going forward. I work a lot on MRI. So MRI can also generate an angiogram of the coronary arteries. And actually, one of the things that we've studied is looking at dilation of the coronary arteries when you give nitroglycerin under the tongue. Turns out that was one of the other findings in women, that even though the angiogram looked okay, the arteries didn't dilate as well. We haven't duplicated that study in women, but that was one of the findings from the National Institutes of Health study. And one can also generate angiograms of the whole heart by MRI. The technology is not as far advanced in MRI as it is in CT, but it's a bit less invasive, no contrast. So there are some advantages if we can continue to develop this. And finally, MRI can also look directly at the heart artery wall, so the coronary wall. And so there's an example blown up here. And so we can start seeing disease build up in the arteries even before it's caused the narrowing. And so this is an area that we're particularly interested in. It's a little hard to see here, but in the bottom where we've blown it up, we've been able to image plaques in patients' arteries and show that you can see not only that the blood area gets narrowed, but that the plaque around it has enlarged. And finally, I'll make one plug for where we're going with our MRI is to go to stronger magnets. So right now in the Falk Cardiovascular Research Building, where Dr. Robbins has his office for cardiac surgery and cardiology, we share that building, and that right now is kind of the home of the Cardiovascular Institute. That we're installing a 3 Tesla MRI scanner for research to continue this development. And this just shows you a preview of where you can go in a scanner, turn on the button, and get actually real-time imaging of your heart and start to see your coronary arteries. So we're trying to get this to the point where it can be a much simpler, quicker, more routine evaluation in people. So cardiovascular disease is clearly a serious issue in women. And we have a wide amount of data that shows that both the symptoms, the diagnosis, and even the disease itself appear to be different in women. Improved diagnosis and treatment in women requires a broader understanding of the disease and more tailored approaches to both diagnosis and imaging. And really, as a preview to what you hear, it's important to remember that heart disease is preventable and quite treatable. So better awareness and diagnosis will save women's lives. Thank you very much.
So what is heart disease? So Dr. McConnell had some great slides showing you how heart disease affects the arteries of the heart. And heart disease happens when the heart doesn't get enough nutrient-rich blood. Heart disease is chronic. It happens over a number of years. And there's atherosclerosis present even in young arteries. So when we have victims of accidents that are very young and we look in their arteries, they do have a little bit of the hardening of the arteries that gets worse as people age. So a blockage can result in a heart attack, which Dr. McConnell showed you as well. And atherosclerosis not only affects the heart arteries, but can also affect the carotid arteries in the neck, causing a stroke. It can affect the aorta, causing aneurysms, and the leg vessels, causing peripheral vascular disease. So this is sort of the slide that tells it all, that heart disease is the leading cause of death for American women. So about 366,000 American women die of heart disease. The next most common cause of death is stroke at 103,000. And as you can see, that's a far behind second. And when people talk about 500,000 women die every year of cardiovascular disease, they're talking about heart disease plus stroke, because this is considered a vascular disease. Next to that is lung cancer. Next to that is chronic obstructive pulmonary disease. And after that is breast cancer. But unfortunately, what women are most worried about is breast cancer, and 10 times the risk is heart disease. And that's what this campaign is about, to make women aware of those statistics. Heart disease is the #1 killer of American women, no matter what race or ethnicity. And heart disease kills 1 out of every 3 American women. So I wanted to show you cardiovascular disease deaths in women and men. So cardiovascular, so we're talking about strokes and heart attacks. So the good news is in men, we started in 1979 with about 500,000 deaths. And over the years, up until 2001, men have been doing very well. We've gotten down to about 430,000 deaths. The bad news is, in women, in 1979, we had about 470,000 deaths. And as time has gone on, we have not done better, and if anything, we've done worse. So this is the crux of the problem, and why we're trying to get more research on women and heart disease and make more women aware of their heart disease risk. So are women aware of heart disease? So the percentage of women who knew that heart disease is the leading cause of death in women, we asked them in 1997, and about 30% of people said, I know that heart disease is the #1 thing that women are going to die of. In 2000, we asked them, and about 34% knew, so a little bit of an improvement. And in 2003, the number has gone up to 46%, I think in large part due to the American Heart Association Go Red for Women campaign. But is the glass half full or half empty? Fully half of the women still don't know that heart disease is the #1 risk. So why don't women take action against heart disease? So when they telephoned women and asked them what they thought their major risks were, and when they found out that it was heart disease, they said, well, why don't you think that you're taking action to protect your heart? So here are some of the things that, that women have said. They don't put health as their top priority. They don't think they're old enough to be at risk. They think heart disease is a disease of older women, but in fact, 9,000 women under the age of 45 have a heart attack every year. They feel too busy to make changes in their lives. They're already feeling stressed or they're tired. So there's a lot of barriers to women making changes. So somebody asked about the differences between men and women and heart attacks. And when I went to medical school, they said, you know, if someone's having a heart attack, they're going to come in, they're going to clutch their chest, and this is called the Levine sign, and they're going to say it's like an elephant standing on my chest. And I'm not that old, but every heart attack I've ever seen, no one's ever said that. But men are more likely to describe those symptoms than women are. So men describe this classic substernal chest pain or pressure. They can sometimes describe pain at rest. They classically describe pain radiating down their left arm and shoulder or weakness. But women tend to be more, so somebody said it well before. They said men are noun-verb people and women are adjective-adverb people, so they describe their chest pain a little bit more. So they describe pain in their, they can describe pain in their chest, but often the upper back is implicated as well as the jaw or the neck. They complain of shortness of breath. And some women just come in complaining of nausea and vomiting and flu-like symptoms. So it's very hard for people to distinguish that this is coming from the heart, people being ER physicians. And fatigue or weakness, sometimes women just say, you know, I just can't do as much housework as I used to. So all of those things should be triggers for you to be thinking about your heart. And they can also complain of feelings of anxiety, they lose their appetite, or just general malaise. And anytime that you have any pain above your waist, you should be thinking about your heart. And someone asked the question about, well, this means that we're going to have more imaging tests for women who don't really have heart attacks. And that's true, and we do a lot of imaging for both men and women in emergency rooms. Not imaging so much as just evaluating them, getting an EKG, getting some blood tests. But my advice to you would be, if you have any doubt at all, come on in. I mean, this is our job. This is what we want to do. We want to make sure you aren't the one that has a heart attack at home. So, and you won't be the first one that comes into an ER with chest pain or another symptom that isn't actually having a heart attack, but we want to send you back knowing for sure. So this is data from the National Registry of Myocardial Infarction. So this is everybody who came in with a heart attack. And this is by age less than 50 to 85 to 89. The men are in blue and the women are in red. And this is death during hospitalization percent. So when people come in for a heart attack, what percentage of them die while they're being hospitalized? So you can see that at every age group, until 75 to 79 or about 80, women do worse than men. So what are the reasons for this? We're still investigating. And there are many things, including most of the therapies were developed and tested in men. Dosing may be different. But this epidemiologic data is what's fueling the research in this area now. So why is there the gender gap? So we talked a little bit about that. Women present to emergency rooms or chest pain centers 1 to 2 hours later than men because they're at home taking care of their families, and you know, they're saying, well, I'm just going to make the bed and then make lunch tomorrow, and then I'm going to go in and see about this chest pain. So, and women do have multiple roles, and they delay their care because of their responsibilities to others. And also, women delay care because they perceive that heart disease is something that happens to the men in their lives, their father or their brother or their spouse, but not them. And now you know, and you should tell the other women in your lives that heart disease is a very important thing to consider. So what are the risk factors for heart disease? So we talk about them as being non-modifiable and modifiable. So these are the things that you can change are the modifiable ones. And the ones you can't change are non-modifiable, and you know the difference because I told you. So non-modifiable ones are age, family history, and gender, if you're a man or a woman. Modifiable ones, and those are the ones we're going to concentrate on today, are physical inactivity, which means that people don't move very much, obesity, high-fat diets, which Christopher talked a little bit about today, high blood pressure, diabetes, high cholesterol, and cigarette smoking. So now we're going to talk about what you need to talk about with your physician next time you go in and see them. So what are the key tests for heart disease risk? One is, do you smoke? And fortunately in California, not many of our patients smoke. But if you smoke, the number one thing that you can do to help your heart is to stop smoking. Next, you should have your blood pressure checked, blood cholesterol. Blood cholesterol should be checked first starting at the age of 20 and every 5 years after that if there's no problem. And definitely around the time of menopause if you've never had it checked before. Fasting plasma glucose is a test for diabetes, and body mass index, which is a ratio of height to weight. And we'll talk about that a little bit more. Are people familiar with body mass index, what that means? Okay. So as I said, tobacco is the #1 preventable risk, and I don't need to tell you that female smokers have 2 to 6 times the risk of sudden cardiac death than non-smokers, along with a host of other problems, including cancers, lung cancer in particular. Secondhand smoke increases cardiac risk. The health benefits of quitting smoking for cardiovascular disease begin immediately. So unlike cancer, where you still have the risk years down the line, if you stop smoking, 5 years from now, you have the same risk of someone who never smoked at all. So it's a great thing to do to quit smoking if you are a smoker. People who quit smoking successfully have tried and failed many times. So if you've tried and failed or know someone who's tried and failed, don't give up. It takes many tries. And there are many low-cost or free programs to help people stop smoking. So blood pressure. Controlling your blood pressure will reduce your chance of stroke by 35 to 40%, your chance of heart attack by 20 to 25%, and heart failure by 50%. High blood pressure is more common in older women than older men. And a woman who has a normal, or any person who has a normal blood pressure at age 55 has a 90% lifetime chance of developing hypertension because this is something that happens as we age. And an optimal blood pressure is less than 120 systolic and less than 80 diastolic. So 120 is the top number and 80 is the bottom number. And anything lower than that is fine too. So lifestyle change, what can you do to lower your blood pressure? Weight loss, you lose about 1 point on your blood pressure for every pound that you lose. So it's about 1.6 for every kilogram. There's a diet which promotes vegetables and fruits, and it will decrease the top number, the systolic blood pressure, by 8 to 14 points. Reducing the salt in the diet, and we recommend less than 2,000 milligrams per day of salt, will decrease the blood pressure by 2 to 8 milligrams of mercury. 30 to 45 minutes of daily aerobic exercise will decrease your blood pressure by 4 to 9 points. And limiting alcohol will decrease your blood pressure by 2 to 4 points. And for the alcohol limit for women is 1 drink a day, and for men it's up to 2. And avoiding tobacco products, as we talked about before. So the lipid profile, when you get your cholesterol checked, here's what your numbers should be. Your total cholesterol should be less than 200. The low-density lipoprotein goal is getting lower and lower every year, it seems, but ideally it should be less than 100, and if it's less than 30, less than 130, that's probably okay. Triglycerides should be less than 150, and the HDL, which is the good cholesterol, should be higher than 40 for men and higher than 50 for women. And lifestyle is the key. So if you change your diet, eat less saturated fat and cholesterol, your LDL, the bad cholesterol, will go down. And if you exercise, your HDL, or your good cholesterol, will go up. So the Diabetes Association guidelines for blood sugar, the optimal fasting blood sugar when you get your blood sugar checked will be less than 100. The criteria for diabetes is a fasting glucose of 126 or less, and a random glucose, which means they check your glucose at any time, even if you've eaten, is less than 200. There's a new category called impaired fasting glucose, and that's a glucose of 100 to 125. So people in this impaired fasting glucose have a higher risk of developing diabetes in the future, and it's about 1 in 4 develop diabetes in 5 years. And people at risk for diabetes, these people in the impaired fasting glucose range who follow a diet and exercise plan with just modest weight loss, with just 7% of their body weight, can decrease their risk of developing diabetes by almost 50%. And this was a landmark study called the Diabetes Prevention Project, which found that diet and lifestyle was better than taking a drug to prevent diabetes. So what is special about women in diabetes? Type 2 diabetes has increased about 50% in the last 10 years, and I'll show you an alarming slide about that in a little while. 2 of 3 people with diabetes die of cardiovascular disease. So 66% of people with diabetes are going to have a heart attack or stroke, and that's what they will die of. Diabetes increases a woman's risk of heart disease by 3 to 7%, and it's a little bit less than men, 2 to 3% in men. So we think that diabetes is a more important, even more important risk factor in women. People with diabetes should be treated as aggressively as those with known heart disease, which means lower goals for cholesterol. Your LDL should be about 70. It's a bad cholesterol. And blood pressure should be around 120/80, and everyone with diabetes should be on an aspirin. And diabetes also reduces the success rate when a woman undergoes bypass surgery or balloon angioplasty. So that's why we see greater risk of complications and perhaps greater deaths in women compared to men. So this is the alarming slide I was telling you about with obesity and diabetes trends. So this is, the top is obesity. And in 1991 and 2001, and the bottom is diabetes in 1991 and 2001 in the United States. And so we can see in 1991, obesity in the U.S., most states were this sort of dark green color, which is about 10 to 14% of all of the people in that state were obese. So obese is defined as a body mass index of greater than 30. So that's me plus 40 pounds, or a 5'5" woman who has a weight of about 180 pounds, just to give you an idea of what obese is. And then 10 years later, in 2001, we see most states are in this 20 to 24% range. So it meant 1 out of every 4 people walking around were obese. And we had a few states that were greater than 25%. So it's just epidemic. And for diabetes in 1991, we had most states in this green color, which is about 4 to 6%. Still 1 in 20 people had diabetes. And now in 2001, we see most states are in the 7 to 8% range, some in the 9 to 10% range, and some greater than 10%. More than 1 in 10 people have type 2 diabetes. So this is really going to be the problem of our future, I think. So there are many health consequences of obesity. We talked about a few of them: high blood pressure, high cholesterol, type 2 diabetes, insulin resistance, which is sort of a precursor to type 2 diabetes, coronary heart disease, which we're talking about now, angina, which is chest pain, congestive heart failure, which is a complication of high blood pressure, strokes, gallbladder disease, gout and osteoarthritis, obstructive sleep apnea, which you may not know about, and other respiratory problems, including asthma, some types of cancer, poor female reproductive health, including infertility, bladder problems like stress incontinence, kidney stones, and psychological disorders, including depression. So obesity itself, unfortunately, has many facets. And when people come to me in preventive cardiology, they're sort of on the verge of being on a medicine for blood pressure, for cholesterol, and diabetes. And I say, you can leave this visit here today with 3 prescriptions, or we can work on one thing that will cure all of them, and that's the obesity part. So I just wanted to say a word about hormone therapy for women, just to emphasize that postmenopausal hormone therapy is no longer recommended as a strategy to prevent heart disease, and these are new results from the Women's Health Initiative. However, hormone therapy, generally short-term, may still be used to treat symptoms of menopause, and this is a decision that you should make with your healthcare provider. So where does exercise come in? Everywhere. Exercise helps lower blood pressure. It helps prevent diabetes, as we talked about with the diabetes prevention program. It helps raise the good cholesterol. It helps with weight management, stress, and helps with bone health and osteoporosis risk. So Christopher gave a great talk on nutrition, and there's just one thing that I would like to emphasize. So you can see that, and the NHLBI has some great slides on portion size on the net. Actually, if you just put in portion size into Google, you'll find these. But so 20 years ago, here was a plate of spaghetti. It's 500 calories. It was a cup of spaghetti with sauce and 3 small meatballs. And today, that same thing, and this is probably less than the serving that you would get at the Olive Garden, I'm sure. So it's about 1,000 calories, 2 cups of pasta with sauce, and 3 large meatballs. So portion sizes are huge. And just as a rule, I tell my patients, if you go to a restaurant, never eat everything on your plate for the main course. You should always take half of it home or share with someone, or if you're going to eat it by yourself, just get the appetizer because it's guaranteed to be too many calories for you. And the calorie difference is 525 calories, which is incredible. I mean, consider a woman of my height and weight probably needs to eat about 1,500 calories, and that would be all I could eat in a day almost. So be aware of that. I think that's a big problem. Okay, so we talked about how to survive a heart attack a little bit before in the Q&A. So again, I don't want you to be the one that's holding back because you don't want to waste the nation's resources. You be the one to call 911 if you're having any problems, 5 minutes at the most. And the emergency medical personnel will begin treatment at once. If you have an aspirin at home, it's probably a good idea to take it. Don't drive yourself to the hospital because you don't want to bother anybody else, you know, so call the ambulance or have somebody else drive you. And uncertainty is normal. Don't be embarrassed by a false alarm. If you go in and they do an EKG and they say everything is fine, that's good, but it will at least give us some opportunity for intervention for your risk factors to prevent a future event. So I encourage you to go in if you have the slightest doubt. So plan ahead and learn the warning signs, which we talked about today. So, but we're going to lower your heart disease risk, so you're not going to have a heart attack and call 911. And to do that, what we are going to concentrate on is being physically active, and the current recommendation is 30 minutes of moderate intensity activity on most days of the week, and most days of the whole week, not just the weekdays. So that's about 5 or 6 days a week. And follow a healthy eating plan. Limiting portion size is key. I think that's one of the most important things. And count calories. People you know, pay a lot of attention to their bank accounts and balancing their checkbook. Balance your caloric checkbook every day. And just in general for weight loss, for my patients, I ask them to shoot for 1,500 for women and 1,800 for men. And if you need to lose some weight, this is probably a good ballpark for you. Most people will lose weight on these types of calories. Have a diet that's low in saturated fat and cholesterol and moderate in total fat. Limit your salt and sodium for blood pressure. And if you drink alcoholic beverages, have no more than 1 a day for women. So there are a lot of internet resources out there, and they're easier to find now with Google. The National Heart, Lung, and Blood Institute, the American Heart Association is a great resource. Women Heart has resources that are specific to women. Smallsteps.gov is an obesity initiative to encourage people to make just small, sustainable changes in their diet and lifestyle. And also the Preventive Cardiovascular Nurses Association, that's pcna.net, and they've also done a lot of excellent work in this area. So in summary, I'd like you to leave here knowing the symptoms of heart disease, knowing your risk factors for heart disease, and if you don't know your risk factors yet, go to your doctor next time and get these tests. When you visit with your healthcare provider, discuss your risk factors and ask questions about your heart tests. Maintain a healthy lifestyle. And remember that heart disease is largely preventable. So with that, I'd like to thank you.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.